Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Foot.
Hello. Today's lesson is the foot exam. We already have our patient up on the table. She has removed socks and nylons, any jewelry that she might have on her foot. We are going to protect her with a lead apron. I have an 11 by 14 cassette out, a right marker because we're going to be doing a right leg, and lead shields here. We're going to do 3 projections. We're going to do a medial oblique, an AP, and a lateral. We will start with our medial oblique, and we're going to put it on the inside of the cassette with the ID blocker to the middle side of the foot. Okay? And we're going to do the medial oblique first because aesthetically this leg will be going off that edge of the cassette. The AP in the center will be straight up and down. And then over here on the lateral side, the foot goes off. So we've got a balance or aesthetic quality of our X-ray. Okay? We're going to have our 40 inches to the tabletop that you've had before. And I want her leg coming out straight. And you use lead blockers. Okay. The knee is going to be rotated in to get the plantar surface of the foot 30 degrees off of the plane of the film. Again, that's 30 degrees off the plane of the film. You do not need to manhandle the foot. Patients in pain, you can manipulate the leg and the foot, whatever you need to do, either the lower leg or the knee. But I'm going to get the plantar surface of the foot 30 degrees off the table. Here's a bump on her foot. That's the mark of the base of the metatarsals. And that's what I want to the center of the film on an average foot. But remember, what is average in our society? We have size 4 adult shoes up to size 14, 15 men's shoes. So sometimes the base of the third metatarsal, it's not practical to go to the center of the film because the foot is so long it won't fit. You'd have toes overhanging and os calcis overhanging. In the event of a long foot, what we look for is that the toe, the soft tissue of the toe, is approximately a finger's width from the edge of the film. So we've got Drea's the bases of the metatarsals to the center of the film, just about. And I have more than my finger's width, so I'm very happy there. I'm just going to want to make sure that I maintain the distance spacing, the toes being a little bit more than my finger's width. I'm going to maintain that all the way across the film to prevent stair stepping. Okay. If the cassette slides on you, notice how it slid on me just a minute ago. A trick is to take an additional lead strip, if it's necessary, and place it underneath the cassette. Actually place it under the cassette, and that will help minimize the slipperiness of the table. Collimation I want just within the film's edge, all the way around. The light equal on both sides, baby light over the lead strip, and the collimator box straight. I'm going to use an R marker. I will choose to put it lower than the ID blocker. Remember to drop down a ways because most of the time these ID labels on the outside of the cassette are not a true spacing to the actual lead inside the cassette. So I dropped the R marker down a little ways. I could also put that R marker to this corner here, even though it will be under the lower tibia and fibula. Those bony structures are not part of the exam. I'm putting it here so you can easily see it. And that's because when we hang this x-ray, the toes will be hung high. They'll be more superior. And you want to be looking at that R marker like this, toes up. Okay? You'll be looking at that marker like that, toes up. Okay. Let me recap. The plantar surface of the foot is 30 degrees off the plane of the film. The toes should be at least 1 finger's width from the film's edge, shooting for the base of the metatarsals, in particularly the third one, should go to the center of the film. If necessary, you clip os calcis on a longer foot, like the size 13. They may not fit because the foot is so long. Os calcis is a totally separate exam, so if you clip that anatomy, that's acceptable for a foot. The anatomy on the side over here, you do not want to clip the navicular. And remember, if we say do not clip the navicular, that means the joint space in addition to the talus, a little bit of the talus. Do not clip that. Okay? My patient, her leg is kind of going off or on. Get the patient stable. Get them comfortable. This is a demonstration, so we're focusing more on the teaching aspect, but make sure the patient is stable there. Okay? And we're ready to go make the exposure. Rotor sap. You may relax. And I'm going to put the AP in the center. Her foot, the plantar surface, will be flat. The leg comes straight up. The toe will stay the same spacing as it was on our first projection. Can we bring your foot out just a little bit? That's good. A little bit more than my finger's width. Foot centered to that unit. The leg straight. Do not forget to angle the tube. Okay? We're going to angle the tube 10 degrees cephalic. And when we angle the tube 10 degrees cephalic, we're going to change the gauge reading to, we're going to drop it down 2 inches. That's the 1 inch for every 5 degree of tube angle. The gauge says 41, but that's actually to maintain our 40-inch reference. Again, do not forget to angle the tube 10 degrees cephalic. Many of the role model techs that you're going to be working with are going to want to angle 15 degrees. That's because that's what they were taught in previous textbooks. Those books were saying 15 degrees. The newer textbooks are saying 10 degrees. Cephalic. You might ask why. And that's because if we take a look at the foot, this projection is primarily after the tarsal bones. And the tarsal bones are at an angle from the plane of the film. And from theory, you want to remember that whenever possible, you should be perpendicular to what you're trying to demonstrate. So we're putting a 10-degree cephalic tube angle to allow us to be 90 degrees to the tarsal region here. Again, you have the same amount of light, top and bottom, here and here. Then you know you have the central ray to the center of this plane, and this crosshair is coming right down the center of the foot with the leg vertical and the plantar surface flat. With a 10-degree cephalic tube angle, and you adjusted the SID to compensate for the tube angle. Now we will make our exposure. Rotor zap. And the patient can relax. Can you pick your foot up for me? That's good. Now I want you to adjust the cassette to the shape of the foot. Drea is flexible enough to where she could have matched the shape of my cassette. Do not make your patients go to your needs. They are uncomfortable. You change the plane of your cassette to meet their comfort zone. And most of the time it means the cassette is angled like that. Is that comfortable enough, Drea? Okay. Do not forget you have a tube angle that you no longer need. So we need to go back vertical. And when you go back vertical, you take your SID back up on the gauge to maintain the 40 inches. I'm going to have to float the tabletop. The tube will not come out anymore. I've got to float the tabletop. And the table won't float anymore. So we're going to be forced to slide our patient over a little bit. That's good. Equipment flexibility didn't permit us otherwise. Okay, you've got equal shadow, equal shadow. You want that? I have a little bit of shadow on this side, so I'm going to show evidence of collimation there with baby light over that strip. I want to manipulate the patient's knees. Watch what happens when I raise and lower her knee. Look at her metatarsal heads. Okay? Your goal is to make the metatarsal heads perpendicular. You want them superimposed, one right on top of the other. So I manipulate the knee to get the metatarsal heads right one on top of the other. And I want that foot straight with the cassette. There we go. Equal shadow, baby light. Metatarsal heads superimposed, and it's extremely important on this surface of the foot to make sure you do not clip the navicular and a part of the talus. And I'm angled, I'm including clear up into her tib and fib on this position right here. So I'm very satisfied with that. The toe, look at the shadow of the toe, because the great toe has so much OID, the shadow extends. So I'm actually physically looking at the width of my finger with the shadow rather than her tissue. I'm looking at the shadow to make sure that I maintained this relationship coming across. Okay? And I'd ask my patient to hold still and I would go rotor zap. The amount of mass on the AP and the oblique, I want to double that for the lateral. Look at the thickness of the foot here. If I used 5 mass here, I would use 10 mass there. If I used 2.5 mass there, I would use 5 mass here. This is an 11 by 14 cassette, an extremity cassette. The ID blocker, just to recap, is on the medial side of the leg, of the affected leg, medial side. And I will do a medial oblique, 30 degrees on that side. I will do an AP in the center, straight on, foot flat, with a cephalic tube angle of 10 degrees. And I will do my lateral with the metatarsal head superimposed. Okay? Patient can relax for a minute. If I were doing her left leg, I would reverse the cassette. So the ID is on the medial side of the leg. I would do a medial oblique on this portion, the AP in the center, and the lateral going off. Longer feet, you never clip toes. Always include the toes. Get those toes a finger's width from the film's edge. It's okay to clip the os calcis. On the lateral, do not lateral and the medial oblique do not clip the navicular. And anything you can think of to add?
Yeah.
Change your SID when you change your tube angle. I'm trying to think of the things that students many times often forget to do. And I think that covers it. Okay. Let me review the PC information with you before we close. An oblique foot is what we suggest you take first with the ID blocker. That will superimpose slightly the bases of the first and second metatarsals will be slightly superimposed with 3 through 5 having space between them. That's the purpose of the 30-degree oblique. Can I put your foot out here, Drea? If you have the foot more than 30 degrees, can you see what's going to happen if we're more than 30 degrees? See how the oscalsis is really going to start to show up? So when you're looking at films, if you don't see evidence of the spaces between the metatarsal, the bases of the metatarsals, I want you to look down here at the oscalsis. If you hardly see any oscalsis, you were too shallow. You did not have enough of a 30-degree oblique. If the spaces are not open and you see a lot of the oscalsis, you know you went beyond the 30-degree obliquity. So you need to be less obliqued. Okay? Now in AP, in the center of the cassette, the PC information is there will be space between the first and second bases of the metatarsals, or the proximal ends will have space between them, and 2 through 5 will be slightly superimposed. And on the lateral, you get the metatarsal heads, one right on top of the other, superimposed. And for the lateral, if the knee is too close to the table, look at the metatarsal heads. See how they're shifted this way? And the fifth, on films you'll be able to see the fifth sticking out posteriorly here on the plantar surface of the side. If you're seeing the fifth, you will need to fix it by elevating the foot. And if it's not lateral this way, the fifth will be projected towards the tib and fib, and you know that you need to fix it doing that. So that reviews the PC information for you. Again, centering is the base of the third metatarsal to the center of the film, but reality says we have a lot of different foot sizes out there. So I'd like you to look at the space between the film's edge and the great toe, or the first digit. Have a great day.